Hello, and welcome to Barry Dunn's podcast, Healthcare Technology Insights. My name is Dan Vogt, and I'm a principal with Barry Dunn and lead our healthcare technology consulting practice. Technology Insights is here to inform, instruct, and energize healthcare leaders. Our podcast will include professionals from all over the nation, bring together key topics for discussion that have a real impact on the healthcare industry. Speaking of healthcare leaders, our very special guest today is Holly McCormack. Holly is the president and CEO of Cottage Hospital. She has a bachelor's in nursing from the University of Rhode Island, a master's in nursing from St. Joseph's College, and most recently obtained her doctorate in nursing practice from the University of New Hampshire. She has over 25 years of progressive healthcare experience, beginning in 1995 at Hasbro Children's Hospital, joined Cottage Hospital as Director of Inpatient Services, moved to the Chief Nursing Officer, and ultimately to the CEO. She was named Nursing Leader of the Year by the New Hampshire Hospital Association. She brings an authentic leadership style, focus on workplace culture, loves community and rural healthcare. And having worked with her for a bit, I would say she also loves innovative ideas, technology, and new ways of doing things to serve the patient and the community. So today we're going to have a fun discussion, I think, around electronic health records, technology, the patient experience, and what's coming next with artificial intelligence and new innovation. Holly, welcome to the program, and thank you so much for joining.
Dan, thanks for having me. I'm very happy to be here and talk about things that are very exciting right now in healthcare.
Awesome. Well, you've had a career that's had a variety of experience from both clinical and leadership positions. For our listeners, just to get a better sense, maybe share more about your experiences and a little what you've learned along the way.
Sure. I've actually been in healthcare my entire working career. I started when I was 14 years old. Red and go black. Red and go black.
Do you need to go, Holly?
Not yet. It's almost like you could predict this.
This is funny. Have them edit this part out.
Zone black is the basement, so I'm hoping that it's just a drill and not something to do with our construction.
I will keep my fingers and toes crossed. I'm just going to record it, keep it recording to make my life simple. And then if you need to go, we'll adjourn and we'll reschedule. And if it ends, what we can do is just take a pause and just start with your answer again. And then I'm hopefully marketing can just snip together my question and your answer.
Okay. Give it another minute or two, and then I'll ask Missy what she knows.
I have to laugh. It's pretty funny.
Well, you said if there should happen to be a fire drill, just be quiet. No, that won't happen.
I jinxed us.
Why don't you say if somebody should happen to stop by with $2 million that they want to donate?
Next time I will. Code black.
Code red, zone black. So it's a fire drill in the basement.
Got it. I only heard the black part.
Mm-hmm. Yeah, code black is bad. That's a bomb.
Got it.
I'll take a fire over a bomb, but
yes, understood. Yeah, I'm so used to in healthcare, everyone flips their badge over, right? And they have all various color codes of what the things mean.
Yeah.
Gold, silver, elopement on an elderly typically, or something like that. And code pink, a baby typically, and we here at Portland, it was interesting. We had the Portland police come maybe 2 months ago and do a training it was like an hour and a half or 2 hour training for anyone who wanted to go CPE on like best practices in an active threat scenario. Mm-hmm. It was a little bit scary, but like good scary, if that makes sense.
We did an active shooter drill probably about 4 years ago now, where the local police came in and we did it as a drill, but they acted it out. So they had an actor that came in as a shooter who was yelling, and it was very like disturbing and triggering and jarring. And we had to tell people it was happening. But even though it was fake, literally hiding in a closet, thinking about, waiting for them to clear it, you start to think like, what if this person really is unhinged? This is the perfect scenario.
Yeah. Yeah, we didn't go that extreme. This is more of the training about what would happen.
Hmm.
But they had some pretty intense videos, kind of simulating, a situation and talking about, run, hide, fight, right?
Yep.
It's the order. And then actually talking about our building and like vulnerabilities of our building. And it was like, oh, okay.
Yeah. So it's over, but they're supposed to be doing a page that says, code red, all clear. They're supposed to say it 3 times and they haven't cleared it yet. So I know as soon as we start, they're going to do that page.
Yeah, all good. Um, Worst case scenario, we just cancel and reschedule, right? Not the end of the world. So
It should be done any second now. In fact, I'm going to have Natalie poke someone.
all right, no worries.
Weird. Have they cleared it yet? Is it a drill?
Code red here.
Okay.
Code red here.
Poor Dan's here trying to record a podcast. Thank you. Well, somebody forgot.
Oh, to clear it.
Yes.
It's funny, the tests are good though because you figured all those procedures, right?
Mhm.
I once did a disaster recovery planning project with a client and we did some simulations afterwards. And it ultimately ended up they did an actual full failover to their backup site, which was intense. We did it like 2 a.m. But in some of the lead ups to it, one of the things we learned is they forgot to like end the disaster and be clear on
That
like
it ended.
when can you restart using systems and so forth, like,
Hmm.
stop using paper. And so it was like, oh, we were very good at declaring the disaster. We were not very good at undeclaring the disaster.
Right. And we have had a fire situation here before where they shut off the alarm, mostly because of the ray of hope. It disturbs the psych patients. Why they're still trying to make sure that everything's okay. So I didn't know if it was drill or if they were still, because then sometimes it goes back on if they haven't figured out the source, because you can't shut off the siren if it's actual.
Understood.
All right, we can start over. Where am I starting from?
What I'm going to do, we're going to take like a 3-second silent break for
Yep.
editing purposes. And then I'm going to redo my question around your clinical leadership experience so they can just grab it in one bite, if that makes sense.
Sounds good.
And I think you were starting to say like you worked in healthcare your whole life. That's where you started and we got interrupted. So, all right. Holly, you've had a career that's had a variety of experiences in clinical and hospital leadership. I'm just wondering if you can share with our listeners a little bit more about this experience and what you've learned along the way.
Sure, happy to. My entire working career has been in healthcare. I started out when I was 14 years old working in a local nursing home as a candy striper. So I would make beds and pass snacks, and I held that role. I became a nursing assistant while I was in college, and then I became a bedside nurse straight out of school when I had my bachelor's degree working in pediatrics for the beginning part of my career. But I always gravitated towards leadership. During that time, I've held positions of a preceptorship. I've been the charge nurse. And so there came this point in time where I decided I wanted to advance my career around leadership. And so I left my position at Hasbro Children's as a staff nurse and a charge nurse, and I did a variety of strange things. I worked at the blood center as a donor room specialist supervisor. I moved from there over to a local maternity hospital where I was the manager over 2 postpartum units, and then I moved to New Hampshire for my director of inpatient position. Around that time, I decided that chief nursing officer was going to be the position I wanted to hold, and so I decided to pursue my master's degree. And I took on that position, and I really enjoyed what that allowed me to do around shaping the way that healthcare nursing is delivered in the organization. And from there, I decided to work on my from my master's degree to do my doctorate, and ultimately took the role as the CEO at Cottage Hospital. I'd like to say that my leadership is more of a common sense approach. I ascribe to the genuine theory of leadership, if you wanted to put a label on it, but I think common sense works well, and it has always worked well for me throughout my career. And I'm very much a people person, and so I like to hear what's going on, hear what challenges people have, and try to figure out how I can fix those problems, what we can do to make things work better, more efficient.
Awesome. Well, thank you for sharing that. And I think our listeners will appreciate the idea of common sense as we explore big, ambitious technology topics, and the fact that you've been everywhere from the bedside to the boardroom, in terms of perspective that you're bringing to some of these topics. So let's dive in a little bit. I think where we wanted to start is Cottage Hospital recently implemented a new electronic health record system, and you did that across the whole health system from inpatient to the RHC specialty care, and you even have a geriatric psych unit as well. That replaced multiple EHRs that you had, around, and intended to advance you forward. Now these are big, hard projects. So maybe we can tell your listeners a little bit more about the project and then a few follow-up questions about it.
Sure. So in 2021, when I assumed the CEO position, one of the first things that I decided to take on was our electronic health record. The product we were using at the time was no longer supporting the hospital portion of the platform. And so we knew we needed to do something, but we wanted to be very methodical in what we did. And so we went through the vetting process of looking at the EHRs that seemed to fit best with our size facility, our needs, inpatient and outpatient. And so we needed to make sure it was something that was going to improve safety, efficiency, needed to be comprehensive. We needed more data. We didn't have data to base any decisions on, and it needed to be affordable. We are a small, independent, critical access hospital, and so it needed to be something that we could afford, but we needed all the features at the same time.
Great. These are, challenging projects, and they're intended for good goals. So we want to explore both sides of this a little bit. So let's start with the positive. What do you think are some of the biggest gains or wins that Cottage has been able to achieve with a new EHR system?
So we are a year out from our implementation, and so there's still a lot evolving, but the immediate bonuses, the positives that we had were increased clinical features, evidence-based practice, things around equity, stroke, sepsis when you're at the bedside, all of those workflows, definitely improvements for us. Charge capture, when you're looking at the financial side, is an important win. And I think I'll probably answer every question by saying data. We have data that we didn't have before, and data helps drive your clinical decisions. Data helps drive your financial decisions. And so having access to the data around the care that you give is very important. And of course, having one seamless platform across the organization. It doesn't work perfect for everyone, and that's very hard to do with an outpatient setting, an inpatient setting, and a psych, as you've pointed out. But it works best for most. And so we're at the point now where we have to optimize it to get it to work best for all.
And just a comment, I like best for most. I think that's a good way to think about it. In my experience, there was an era of best of breed where everyone looked for the best thing for each niche within a health system.
Yeah.
And then they found that they couldn't achieve what you're touting there, which is the data. The data became unwieldy and unmanageable with that
Right.
strategy. And so people have evolved to more of a single platform with the pursuit of data, but it does require that best of most mindset, which is sometimes hard to achieve. Any thoughts on how you've been working through best of most?
I think it was setting expectations appropriately right from the get-go. We did involve just about everybody in the decision-making process. We had demos, we collected input, and then we addressed the concerns when we finally made our choice. Those that if X concern was raised, here's what we're going to do about that, or we really can't do anything about that, and I'm sorry, but those concerns were never around safety, patient safety, clinical quality. So those are not things, but there are issues where maybe somebody has to click a little bit more than somebody else does, but there's also other ways around that. And when we get to the later in the conversation talking about AI, we can talk about how some of that is being addressed, particularly like in the outpatient clinic setting. But you're right, with all the different segmented, you could get the best in breed in outpatient, and you could get the best in breed for psych, and then the best in breed for the surgery center. But if you can't share data or patient information across all of that, that's where it becomes dangerous.
Yeah, well said. So let's turn it around a little bit, because these aren't all fantastic all the time. So let's talk about some of the biggest challenges you've run into with a EHR project of this size.
I think the biggest challenges with the conversion have come out of the product of the time. So workforce issues are everywhere. And so doing a conversion at a time where we're experiencing workforce issues and where the vendor has been experiencing workforce issues, I think that prolonged the project. There was a lot of what felt like redos of things when you have somebody working, with the vendor on a certain part of the project, and then they lose somebody from their team and you have somebody else pick up. And so having consistent teams would have made that much smoother, but that's what we're dealing with now. So that's life in the big city, or the country, however you want to look at it. But also the other challenge is the financial implications of a conversion. You have to be ready for it. I don't think anybody can ever be completely ready for it. But there is a slowdown in your cash flow, and you can do all the things and you can ask all the questions, and it still happens. We know here that clinical recovered first. We went live. There were, a few little bumps. How does this work? How do we do that? We're able to smooth those out. And so we can provide high quality care. Now it's getting paid for the high quality care. And that's where we are 1 year out, is trying to smooth out those bumps in the road.
Fair. Well, it sounds overall fairly good, but not without bumps in the road. And that's to be expected, I think, with something of this size, scale, and complexity. I guess for any listener who might be thinking about doing an EHR project like this, particularly those who might be peer community hospitals like yourself, any advice you'd have for them heading into a project like this?
The first thing I tell anybody who asks is to work with a consultant. You need somebody who can help you know what questions to ask. It's impossible. And from my position in the CEO seat with a clinical background, I know a lot of the clinical questions to ask, but maybe I don't know all the financial questions I want to ask, or I don't know the big picture about rolling out a project like this. I mean, there's a ramp up before you switch on, the go live switch. And so there's a lot that has to happen in that time. And knowing which questions to ask, because it's mission critical that it goes right when you say go. And there's that point where you have to have your no or no go, and you have to have the confidence to say no if it's not right. You got to know it won't be perfect. It'll be pretty good when you go live, but you got to feel good about that pretty good. And so you need to ask the questions and not move forward if you're not satisfied with the answers. Asking, if things are meeting the benchmark, what is the benchmark of this? Where are we? And making sure those things happen. And somebody wise told me, test, test, test. And so we tested everything. I think probably more than anybody has ever tested our vendor before. And I'm sure there was frustration on their side with us, but we have a lot at stake as I've said before, an independent rural critical access hospital. It had to be right, or it had to be as most right as it could be.
I think that's good advice, and I'll echo the test. And I think that is, a part of the project that's probably least glamorous, most frustrating, and really, really hard to do, and can be a really time commitment by an organization. But, for our listeners, I would say the time spent up front is going to be minor compared to the time spent fixing it after the fact. So I'll just echo the test mindset. Let's switch gears a little bit to something maybe a little more forward looking, a little more exciting. It's being talked about a lot. So we talked about the foundation of putting a new EHR system in, and your next foray is really focusing in on artificial intelligence and what artificial intelligence might be able to do currently and into the future at Cottage. So perhaps share a little bit of what you're doing now, and then we can start to speculate into what you're going to be doing next.
Sure. So best for most was the thing that opened the door to Cottage looking at AI. So we had a provider say to us they were spending a lot of time in the system with extra clicks and things that were taken away from their time with the patients. And they had heard about this thing called ambient technology, transcription technology. And what do we know about that? So that started me asking the questions and speaking with my CIO to say, what do we think about this? Is this something that we can really do in a small critical access hospital, or is this something that's meant for the big systems of the world? And if we do it, how do we do it? And so I did a little research, and then I did a little more, and then I realized I was fascinated about this, and I love to make things work well, and I love to solve problems. And I realized that this would be a great way to do that. And it was just one thing led to another. And I realized I was going down quite a rabbit hole with this. And in speaking with my CIO, he raised concerns about cybersecurity. And, I'm not sure if this is right for us. So I decided we needed to do this in a very methodical way. And so we established an AI steering committee. And the AI steering committee brings together 7 different members of our staff who have different areas of expertise that can help us look at a potential product or project and decide if it's right for the organization. The goal of the team is not to implement whatever we have assessed, but it is to go through it and look at it from various viewpoints. We have our CMO who looks at it with the medical provider lens. I, as a CEO, am the executive sponsor. Our CIO, of course, is over cybersecurity. Our chief nurse looks at it more operationally. We have our quality director to look at quality and risk. We have representation from ethics on our committee. We have a board member on our committee because we want the perspective of the community, and also somebody who has an investment in our organization. And then we have our director of clinical and financial applications, who actually was the oversight for our EHR conversion. And so this group meets, and we decided we'll start right off with this first project. But first, we have to develop a charter so we know what the purpose of this committee is, and how it will work, and how we'll make decisions. And so it shouldn't just be developed just for this one AI transcription project. It should be done a committee that can move forward with just about any other process or project we want to do. And so we put all those things into place last summer, and we've kind of moved our way now through our first project. We had given it the green light in December, and so now it's hopefully about 4 weeks from go live.
Well, that is exciting, right? Not
It's a lot.
only, yeah, it is a lot. And not only the kind of the governance side of how you do this methodically, as you described, but then your first project, right? With transcription and trying to pull some inefficiency out of what you do.
Right.
And use AI for that. So I guess my follow-up question is, what are you and your team, maybe your committee, learning so far about AI and how it may be most helpful at Cottage?
So after, we had a kind of a little bit of a jump start with knowing what we wanted to look at for the first project, but trying to figure out what we take on next is, I think, going to be a little tricky because there's so many products out there, so many solutions, and also so many vendors. So it's so important for us to have this process in place to make sure we are identifying vendors that we work with that will be safe. We need to know where our data is going, how it's utilized if it leaves the organization, what happens to it. And we also have to internally assess the team's readiness for change that might be utilizing this product. And so we don't want to bring in a product that's supposed to make things more efficient and have it complicate matters right now, especially with having done just an EHR conversion. And so, each area that is going to put forth a need or a use case for AI also needs to put forth who's going to be their lead for their department for that, and who's going to lead their change in that area. Because I think initially when we started rolling this out, everybody thought, well, I was so excited about it, so I must be in charge of it all. And that's not how it's supposed to work. It's supposed to be that I am, helping to move this along, but we need buy-in from everybody in order for it to work well.
Yeah, I really appreciate you sharing that perspective on the organizational change component of this too, because I think we can get fixated on the technology and the kind of the whiz bang of all of this.
Right.
And it is going to impact people, and having that sponsor, like you're describing, at each initiative level, I think will really help communicate why are we doing this, how is it going to make my life better, day to day, maybe confront concerns. Anything new, and AI is quite new, I imagine are going to raise some concerns out of the group. So I think the sponsorship model, helps. Maybe elaborate further on it. Like, what are some of the concerns that are rising up as the committee looks at AI and different specific initiatives? You've hinted at a few, but I'm curious what more are coming out.
I think the biggest concerns are, is it safe clinically? We want to make sure that if there are any, the algorithms that are in the background are safe. If there's clinical decision making that's happening in there, we want to make sure we know what the pathways are, how that flows, and the explainability of what's going to happen in the background. Cybersecurity, huge. We need to know if our data is being collected, how it's being collected, where it's being stored, what happens to it after it's utilized for whatever process it's obtained for, and knowing what's going to happen with that. And then also looking at potential for bias in data sets of information that's being collected through our organization. We know we have a very small population here, and so we want to make sure that things make sense for us. And so asking questions about that, if particularly in the clinical situation, utilizing AI. And so those, I think, are the top three things: is clinical safety, cybersecurity, and potential for bias.
Awesome. Are those some of the attributes you wove into the charter, your AI steering committee charter too, so that the committee is kind of screening any initiative for some of those factors?
Exactly right. Yep. There's the charter, and in addition to the charter, there's actually a set of evaluation questions that we use, and there's suggestions also for KPIs that we'll track. But those are additional things outside of the charter, but absolutely things that are built in. So questions we remember to ask every time.
That's excellent. I think with a rapidly evolving technology like AI, having that kind of consistent checklist approach can help you not skip a step.
And the charter actually says that we'll review the charter annually, because like you said, everything is changing so quickly. What makes sense now, we may learn a lot more over the next 11 months. And so at the 12-month mark, we need to look at this again and say, is this still meeting our needs?
Awesome. Well, let's keep talking about AI a little bit more, but let's maybe adjust what we're talking about. We talked a lot about what COD is doing, and I think people appreciate kind of the structure, approach, methodology, and initial use cases you're finding. Let's look out a little bigger and wider, and I'm curious what you and the committee are thinking about largely is the efficiency gains or the improvements, because you're exploring these things and it's starting to paint a picture of what could be done in healthcare.
Right. So if you think about just the advances in healthcare technology, even in the last 10 years, it's mind-boggling to think about. So to think about where we're going to be in 2035 with medical technology and the usage of AI, I can't even begin to fathom what that looks like. But I'm hoping what it looks like is more time face-to-face with patients, less time doing administrative tasks, and maybe also a better use of that data that we talked about to help us figure out clinical pathways and improve care, I think make it more efficient. I think the possibilities are pretty endless there. So I'm not exactly sure where it's going to go, but I'm excited for where it's going to go. And I want us to have a front row seat in that.
I think that's well said, and trying to speculate 10 years out on this is probably a unreasonable lift, but the idea that efficiency data, more time with the patient, more time, interacting and having meaningful conversations because the efficiency is being improved upon on all those administrative tests seems like a reasonable bet to be making. You mentioned there's a board member on your AI steering committee, and you alluded to the fact that A, it's important. So you want someone who's vested in that, but B, the impact on the community, right? And the board obviously thinks about the community you serve quite a bit. So as you think about your patients and your families and your communities and these advancements in AI, what are they saying or thinking? Are you hearing from them at all on these topics?
It's interesting because everybody is talking about this topic. Every conference you go to, you hear it, and then at the local level, you're hearing it. I'm speaking next week at our local Chamber of Commerce meeting because the local businesses want to talk about it, and they have invited me to speak from the healthcare perspective, and then they have somebody from the local bank who's going to talk about how AI is affecting the banking industry, which I can't wait to hear that because I'm not sure in my head what that looks like, AI in the banking industry. So there's a lot of buzz about it, but then there's also, I heard somebody recently use a phrase, dehumanizing healthcare. And I try to, when I hear something like that, explain how that can be untrue, the dehumanizing of healthcare. But if you're going to use ambient technology in your primary care office, this allows your primary care provider to put down that computer they've been carrying for the last 10 years when you go in for your physical and they're typing while they're talking to you. They get to put that aside because with ambient technology, they don't have to have that barrier between them and the patient. They can go back to having conversation face to face with patients and hands on with patients. So I try to explain that part of the dehumanizing healthcare myth that I think is out there. But I do think the response is mixed. I think there are folks in the community who are excited to hear what we're doing about it because they're happy to hear that we are keeping up with the cutting edge of technology and that we're doing it in a safe way, but also that it's not a replacement for clinical judgment. The American Nurses Association came out with a position statement that reminds nurses that AI is a tool. It's another tool that they have to use. It doesn't replace their judgment. It's something that they have to use in their care. And so a lot of other professional organizations are incorporating that into their position statements on AI. And so just reassuring folks that that's what's happening. And we are making people aware in an area where AI is going to be used. Language has been added to consent. So people are aware that it's something that we do. And I think we have a responsibility to do that and allow them information from our social media and our websites and things like that. We'll be incorporating that as we roll out this product, but we need to allow people the opportunity to ask questions.
That'll be interesting. I don't know if you've faced this question yet with like the ambient technology, right? Because the idea of dehumanizing healthcare is interesting. We're at least right now in this era trying to focus on maybe dehumanizing the administrative burden of healthcare,
Right.
and which should enhance the humanized part of healthcare. We can have that nice conversation with your PCP or your specialist or whoever it may be that you're meeting with, and spend more time with a physical exam, spend more time understanding the history, spend more time understanding what the situation and the technology is doing the work of recording and documentation and all the other burdensome components to it. So on one hand, it may humanize it more than people think.
Right.
Have you thought about, and maybe the committee has faced this, maybe they haven't, will people be able to opt out of this in patient visits, or is it going to be an all-on sort of situation?
I've thought about that. And initially with this particular project, there is the ability for them to opt out at this point in time. It's actually the ability for the providers in our clinic to opt into using. So not every provider at this point is being required to use it. It's a tool we're giving them to help make things more efficient, but also to decrease their after hours documentation time. We have one provider when we were collecting baseline KPIs who in the month of November had more than 24 hours of what we call pajama time of documentation. So that's a full day spent outside of her clinic hours documenting, catching up on her notes and whatnot, that this technology should all but eliminate for us. And so thinking about having, gained that time back for that provider, what a great retention tool. But for now, the providers are able to opt in, and if a patient is uncomfortable, they can opt out. That may change over time, but that's where we're able to be right now with this particular project.
And it seems with any new technology, that seems consistent with what I think we've seen with technology evolution in healthcare. I think HIEs early on was very much like an opt-out, opt-in sort of mindset, and then it became more and more common that patients wanted their data shared with
Yes.
other healthcare providers, so they weren't repeating the information. So it seems like once the value starts to become more and more apparent to the patient, then the acceptance becomes a lot easier. So
I think we need to be able to answer the question for them, what happens to their data? And we can with this particular product. We know once the note is written, the data is not saved or stored anywhere. And so being able to assure them that their data is safe, I think is important.
that makes a lot of sense. Well, let's bring this home then. We have one, final question. And, I first off want to thank you so much for your time today. I think our listeners will find this both exciting, informative, at the right points, maybe a little scary, and that's good. But more so help them plan where they may go if they do an EHR, or they're planning for AI, or they're doing all the above, because that's the world we're in. So thank you for that. My colleague Danny, who you know as well, and he's retired now at this point, started a tradition with this podcast that we like to end with, and it's an open-ended question, and it goes something like this. You have an unimaginable amount of money that you can use and at your disposal, and you can use it on healthcare technology, and there's no regulations that you have to concern yourself with here. What would be your top priority and why?
That's such a tough question to answer. First of all, as a CEO, I can't imagine ever having unimaginable amounts of money to run my hospital. And I would say unimaginable amounts of money. I would like to figure out how to make healthcare efficient and meaningful for all. But I also think if I have this huge, lofty goal out there where I could just do anything, I think about a theme throughout this conversation has been data, and all this data is being collected, and we're collecting data through AI. But what if we could algorithmically solve for X when it comes to something like cancer? We can say we have collected all this data, and we know if we have this, and these other 4,000 things come together, that we can predict somebody that is going to have this disease, whether it be cancer or something else, and use that data to do more preventative medicine versus, reactive type medicine. And so I think those things are happening somewhat, but I think we haven't even just, nicked the iceberg of all the data that we could collect and use to make decisions and to guide us into those territories. But the other side, there's like always an angel and devil on my shoulder. And I think about ethical concerns with that and how does that play out? And so fascinating topic. I think I could talk about AI and its possibilities for hours and hours on end. But it's been fun to think about that a little bit. But I don't ever want to take out complete regulation, because I do think we always need some kind of guardrails to work on. It makes me nervous to think that people could do anything they wanted without any regulation at all. So I'm going to always argue for that. I'm a rule follower.
I appreciate bringing us back to earth on that. I think the premise is just an unconstrained problem solving, and I do like the idea that what could data AI do for preventative and precision medicine, right? Can we be ahead of disease, not reacting to it? Can we prevent, not cure, right? Can we do these things? That's an interesting goal and doesn't seem out of reach in our generation, right? And
I think it's attainable.
And the ethics concern is interesting, right? So if you're predicted to have this disease, how do you prevent that from being maybe a problem for you somehow, right? And maybe that's where the regulation, comes in your thinking. So that's a good one. Let's see if we can prevent some things before they happen.
Right.
Well, Holly, thank you again so very much. This has been fun. I think our listeners will enjoy it, and I certainly did. So thank you for being here.
Thank you for having me. It was a lot of fun.
You can find our podcast on iTunes, Spotify, SoundCloud, and Google. Our next show will be coming soon. We hope you will tune in. I'm Dan Vogt, and you've been listening to Barry Dunn's Healthcare Technology Insights. Thank you for listening. Be well and stay insightful.